Thank you very much. Thank you, Manos and Manos, for inviting me here. It's my first ever trip to Greece, so I've been really looking forward to it. So we're going to talk about a very different population of athletes to the overhead athletes, the collision athletes. And this is a large part of my practice in Ireland. I would say more than 90% of the instability that I see are in collision athletes, and mostly male. These are my disclosures. So when we're thinking about collision and contact sport, the definitions technically are that the collision athletes are purposely colliding or hitting each other or the ground or their surroundings with significant force. Contact athletes, while they have contact with each other, it's perhaps less purposely. And there are sports then which are limited contact, where the rules actually specifically are designed to limit the amount of collisions. The sports that we have in Ireland that are the most common collision sports, rugby, and then we have two national sports, Gaelic football and hurling, and you may not have seen these sports before. Some of these are older clips, that's not allowed anymore, but you see the collisions that happen in these sports. They wear helmets now in hurling, not in football, but not really much or any other protective gear. So these are the patients that we're dealing with in terms of how their instability first happens, but also in terms of what your reconstruction has to stand up to, because 99% of these players, when they come in, they want to go back to sport, and this is what they want to go back to do. And that certainly plays a role in our decision making. Sorry, so these guys use the word shoulder as a verb. So they come in and they say, I shouldered the other player and then my shoulder dislocated. So they're using their shoulders as battering rams a lot of the time, and you really have to take that into account in your decisions. We have a shoulder instability registry at Sports Surgery Clinic, and when we looked at mechanisms of injury in Gaelic football, by far the most common was tackle and contact, followed by falls. Slightly different distribution in hurling, which is the sport played with a stick, but again, it's tackles and collisions, and falling to the ground with the arm outstretched over the head was relevant. So the challenge in terms of decision making in these patients comes when the patient doesn't necessarily have any severe bone loss. So for example, this is a 17-year-old footballer. He's dislocated 3 or 4 times now. First dislocation was at age 16, and his x-rays don't really show any major bone loss, maybe some lucency around the tuberosity. We had good discussion this morning about MR versus CT. Where I trained, we used CT arthrogram for instability. And I think that, for me, I know that they have a labral tear if they've dislocated, unless they're hyperlax, which these guys generally are not. And so I'm more interested in the bone. But we have a situation where the insurance companies in Ireland don't pay for CT scan and they pay for MRI. So usually we end up with MR arthrogram. So in this particular patient, he's got a little bit of flattening of the humerus, small hill sacs maybe, but no significant bone loss otherwise, labral tear anteriorly. So that becomes a tricky decision, because he's young, so his age at first dislocation is relevant, not so much bone loss in him, and he wants to go back to a collision sport like what I've just shown you. So when I first started in practice, having come back from the US, I would have done an arthroscopic Bankart in him without really thinking twice about it. And for the first 2 years, those were doing really well. Then I had the first failure and then a couple more failures, and I thought, okay, we need to look at the collision sport athletes and see what's happening. So we had 57 shoulders, all had subcritical or no bone loss, because I was doing Latarjets in some patients where I felt it was indicated. And we looked at them, following them after they returned to sport. They ranged in age from 13 to 35. And yes, the return to sport figures look good. More than 3/4 are back to their sport at the same level. But when you start to look at episodes of recurrent instability, subluxations and dislocations, about 20% each, and 16% revised to Latarjet. And the thing that was most significant in predicting recurrence, as you might expect, was the age at the first dislocation. And if we think about our French colleagues, we have a lot of different operations for shoulder instability, and it's confusing and we're not sure what to do. But in France, the decision is simplified, okay? Because, they have made that operation seem easy. But why don't we do it for everybody? There is some hesitation as regards complication rates. It's controversial, and I think that the more Latarjets you do, then obviously the more comfortable you are, probably the lower your complication rate is. In the US, when we looked at nerve injuries, there was a pretty high proportion that had nerve alerts on neuromonitoring. Whether those translate into something clinically important or not is a different question. But also with a Latarjet, particularly in these younger patients, as Katerina mentioned, the bailout options are difficult if a Latarjet fails. So when a Latarjet goes wrong, this is a much more complicated situation than revising a failed soft tissue procedure when you see some of these cases that present and what you have to deal with. The nerve injury question really was something that J.P. Warner highlighted in a study that I was fortunate enough to be able to do with him when I was a fellow, where we monitored sensory and motor evoked potentials intraoperatively during Latarjet procedures to identify which points in the procedure the nerves are most at risk. And doing something like this would give you a healthy, this is a video from one of JP's cases, give you a healthy respect for what we're actually doing when we do something non-anatomic. And you can see on the left the baseline motors, where the axillary musculocutaneous nerve in the top left are responding normally to stimulation. We set their baseline. On the right, the baselines are green, and you see that the white line is flat for the axillary nerve and the musculocutaneous nerve. This is happening as the anterior glenoid was being exposed in that particular case. So it's always worth, I think, respecting that operation, even in the collision athlete population. So back to that case where he had minimal to no bone loss. He's only 17. He's a collision athlete. We know that an arthroscopic Bankart is probably not going to be good enough, because we see in this population 20% failure rate at 2 years. Should we add a remplissage? And Alex Lederman and Pat Denard have published recently on reducing recurrence rate by adding remplissage, but those patients were not this population. They weren't engaging in the types of sport that we're dealing with in our country. Is it aggressive to do a Latarjet when there's no bone loss? It's non-anatomic. Perhaps the complication rate's higher. We've seen from Di Giacomo that the resorption of the graft happens, particularly when there is no bone loss, is a reasonable compromise in open Bankart. And for a time I wondered that, and that's what I did for that patient, as you see on the right. But when we looked at our under 18 collision athletes, specifically in that age group, very similar to the arthroscopic Bankart, these were the majority playing at competitive and elite level. Again, 90% return to play, a decent proportion at the same or higher level, and their patient-reported outcomes were looking good overall. The shoulder instability return to sport after injury score, the CIRSE score, is one that people may not be as familiar with, and is quite useful because it takes into account some psychological factors in terms of return to play. However, when we look at recurrent instability, again, very similar figures to what we saw with arthroscopic Bankart. So it seems that the soft tissue procedures in our collision athlete population are probably not good enough in terms of the recurrence rates for instability. And then when we look at returning these athletes to play, typically we have arbitrary timelines. We know that the bone block heals in about 12 weeks, so we start to let our Latarjets back to contact training at about 3 months, unless there are any problems in their rehabilitation. The soft tissue procedure, 6 months. The players talk to each other. They come to the office asking for the 3-month procedure, asking for the bone block, and it's our job to sort of explain the differing complication rates and the risk-benefit balance for these procedures. We had been using isokinetic testing as a way of evaluating when a collision athlete was ready to go back, looking for a difference of less than 10% compared to the other limb. But in some cases, this doesn't tell the full story. So this is my first arthroscopic Bankart failure. He's captaining the under-20 Irish rugby team, and we did push the envelope in terms of time to return to play, because this is the under-20 World Cup, and he's going to tackle the number 5 from New Zealand. They're playing in the semi-final here. So you see what happens to his right shoulder. There goes your arthroscopic Bankart. That's it. And so you see that again. He says that he went into the tackle on the wrong foot and that there were some technical issues about how he tackled this much bigger player. But I think it's a good example of how the soft tissue procedures just sometimes are not enough to withstand the forces in these collision athletes. And I suppose one logic is that if what nature created as a shoulder is not good enough to begin with because it dislocates during these sports, then just putting things back the way that nature created them is probably not going to be good enough. I revised him to a Latarjet and he did well. But you see his isokinetic testing before we let him back to play, he was doing really well. In fact, his operated side was testing stronger than the non-operated side. But when I scoped him, we saw the damage. He had disrupted his repair and ended up with a Latarjet, and then went on to have a good career in professional rugby. But so the isokinetics are not telling us the full story, and we need something better. And this is where we started to look at upper quadrant functional performance tests. Our senior shoulder physiotherapist, Edel Fanning, has just completed her PhD on this work. And so using force plates, looking at these different tests, the person doing the testing has these markers attached to various points on their upper extremities and their thoracic spine. The Vicon system then registers the person, 2 hands, 1 on each force plate, and we have them perform these different tests. For example, counter movement press-up jump is this one. And you can see what this looks like with the actual athlete on the plates. Edel's first work was to go through a large population of uninjured male contact athletes to establish norms, because nobody's been working on this, so we don't know what it should be. What's normal limb-to-limb asymmetry, accounting for hand dominance, and different factors. And so she established norms and is now looking at all of the post-operative instability patients. And so different parameters were established in terms of jump height and concentric impulse, for example, in this press jump, and also what the sort of acceptable difference between the 2 limbs should be. The box drop landing is the one last test, and this one's sort of interesting because it looks very simple, but when you actually do it, it does take a fair bit of trust in the shoulders to come off these low boxes and land on the 2 hands, and we can see then if the person is offloading one shoulder versus the other. And so the collision athletes have the option to enroll in this return to play program, and typically at about 12 weeks is when they first do their first set of tests, and we don't expect them to be anywhere near ready to go back at that stage. We still do use isokinetics and generate a report based on peak torques and inner and outer range and internal external rotation, and a set of recommendations then that go back to the local physiotherapist for the collision athlete. And so very quickly, the recent publication from Edel with our patients is that there is still persistent asymmetry on isokinetics at 6 months in most of these patients. At 6 months post-op, when we as surgeons think that they're finished their rehab and ready to go back, they're achieving only half the body elevation on those jump tests that the uninjured controls are achieving. And we see that there are still asymmetries on those functional tests. Yes, they're better at 6 months than they were at 4 months, but at 6 months, they're still not as good as the uninjured players. So yes, the anatomic injury is relevant, bone loss, on track, off track, maybe, we don't spend time calculating that because probably the bigger factor for us is the activity. So once they're a collision athlete, we have a very low threshold to perform a bony procedure, and possibly even collision sport is an indication for a Latarjet. It's a shared decision with the player and often their parents if they're younger. And return to play, we still need to do more work because they may not be ready when we think they are, and this may then play into some of the recurrence rates that we see in this population. Thank you.